Good afternoon. Now we are going to have a session on for the crisp vision. What beyond surgical excision? Apart from the surgical excision, what we can do? I invite Dr. Rakesh Shekia, Dr. Rajesh to come on the dais. And we have our expert panel, Dr. Ashok Shroff, Dr. Harbans will be joining, Mahipal, and Dr. Puran. Dr. Mahipal, please join. Rajesh. So as the time is very short, it is a squeezed into the 1 hour. वो काउंसलिंग से स्टार्ट करना पड़ेगा. Okay. So I will start that topic. So first we start choosing the right IOL. I invite Dr. Harbans to speak on the right IOL. Harbans, please, because he is our president, so always in the rush. President is always in the rush, so he is. Past to past ही हो गया बहुत. So.
He does not have
and we have to give the privilege to the president also, man. So that's what he says, we have to obey. Along with this, we have the talk with Dr. Rajesh Joshi. He will be speaking on the counseling. Then Dr. OP, how the extra thing we can do and the toric marking. Dr. Rurija for the eye trace and topography to give you a clear vision. Dr. Mahipal for the advantage of the femto, extra advantage, but for clear vision, not for the surgical technique. And Rajesh Joshi on counseling. Ashok Shroff will be topic. Ashok Shroff.
So how much is time?
It's right type of the biometry.
So how much is the time for me?
Well, Dr. Bhasin, please join on the dais.
Time per speaker 6 minutes.
Because it was 1 hour,
Yeah.
1.5 hour session is squeezed to the.
So how many minutes?
6 minutes.
Okay. So
And it is
I'll
strict,
finish it.
strict 6 minutes.
Okay. Now put it on a 6 minute पे timer लगा दो.
Timer for the 6 minutes.
यहाँ तो 6 पे आ गया कि 7 पे आ देगा? 6 कर दो 6. So as we know, in a photography, there are two types of lenses, primary versus zoom. So primary lens is single focal lens, which gives the wide aperture, fast and crisp and a sharp image whenever you do wildlife photography, but not so popular, very expensive. On the other hand, zoom lenses, they are more popular because of their flexibility and range. Same way, every patient will like to see from 33 centimeter to the infinity if that can be achieved. And that is possible with the EDOF trifocal lenses. But they have got their limitations like ocular conditions, whether it's a dry eye, corneal, vitreous, retinal, macular, optic nerve, any problem anywhere, the multifocal lenses are not suited. Then they have got added photic phenomena, halos, glare, starburst. Then there is a contrast loss and there is a cost involved. And explant of the multifocal lens is not so uncommon. So when we select the IOL, we have got to see the finances, profession, ocular conditions and limitation patient has got. Any patient will like to have a good distance vision, plus minus 0.5 is acceptable, maximum -1. And for intermediate vision, patient will have to have around -1.25 to -1.75. And this has become very crucial because of the use of the WhatsApp, email, Candy Crush, movies, videos. So near vision is not as much required, but if we need -2 or -3 will be needed. Now, can I have a pointer, please? If we have pointer, if we see the synergy lens or the trifocal EDOF lenses, they cover 33 centimeter to the infinity. Symphony or BFT type of lenses, they will cover from infinity to around 1.5, 1.75. And the premium monofocal have got 0.5 to 0.75 addition, so they will cover infinity to 150 centimeter or so, and monofocal will be having a very crisp range for the infinity only. So now if you want to use the synergy lens, this is covering for infinity to 33 centimeter. If patient becomes myopic, this 33 centimeter becomes 25 centimeter, which will be very uncomfortable for the patient, and he will miss on to the distance vision. So rather, if you want to err on this synergy lens, patient should shift on this side. If it becomes plus 0.25, he is still seeing clear for distance, and his reading distance becomes little more, will be more comfortable. So if you are using synergy lens or the high power lenses, it could be little plus, but not on the minus side. On the other hand, if you are using a symphony lens, so if it is plus minus 0.25, a patient wants primarily for distance. Even if it becomes plus 0.25, he'll be able to see clearly for a distance. But if it becomes minus, he will not be able to see for distance. But if patient wants little more near vision, not only for a mobile and for this, then you make first one eye 0.25, another eye minus 0.75, then he will come to this 40 centimeter range, which he can read the finer prints. And mind you, this print, this reading is 40 centimeters for N6 or something. So when the image is enlarged, patient can read mobile very comfortably, or the print like the religious book he can read very comfortably even with these lenses, even if you don't adjust for that. On the other hand, if you are using a premium monofocal lenses, this has got an advantage. The patient wants a crisp, sharp vision. Even if it becomes plus 0.25, he'll see clearly because it has got plus 0.5, 0.75 addition. So slightly patient wants crisp vision, even if it's slightly hyperopic, it will do. But a patient wants a little bit of a mobile vision, then you have got to keep one eye minus 0.25 and another minus 0.75 as in a symphony, so that he can see a little bit of with the mobile phone, which has a bright screen and a larger letters he'll be able to manage. Monofocal will give you only crisp vision for a distance. This is best, and ask the patient, that many patients feel their personality suited when they use the glasses. This is perfectly alright to correct for distance. But if patient wants some of the mobile users, you will have to keep one eye around minus 0.5, another eye around minus 1 to get him some near vision. So depth of focus also depends upon the pupil size. If the patient's pupil size is small, many patients you will see that they read 6 and 6 without glasses because the pupil is very small and pinhole effect is there. If patient is astigmatic, it will also give a depth of focus. If patient got a higher order aberration, that means if you use the regular lens instead of aspheric lens, he will have better depth of focus. And if some of the patients, when you see, they have got a supernormal vision, 6/5, 6/4, 6/3. So these patients, even with the distance, can read very well without any addition or without any multifocal lenses. So we know what we want, but how to avoid it, for that we need to understand the biometry. I think I'm not going to the details of biometry, but one thing you need to understand is this half a diopter change over here translates into 0.33 diopter over here. So like in the synergy, if I'm choosing IOL, I'll choose between minus 0.10 to plus 0.23. This will be the anything between, because every biometry next step is in a 0.33 step, because the IOL power is half. So synergy I will use, even if it is minus 0.1 is acceptable, but minus 0.25 is not acceptable to me. So the symphony and vivity I will use minus 0.25 to minus 0.58. So slightly myopic will help me. Monofocal lenses distance I'll use first minus, whether it's within 0.33. Second eye I can use the one eye maybe around 0.67. And premium monofocal will be the same. If patient has got a strong desire to have a clear distance vision, choose like synergy, that means slightly plus, there is no harm. But if he wants a little bit of intermediate vision, use like a symphony, that means slightly on the minus side. So second eye need, when we are looking at the second eye, we have to see the result of the first eye and adjust the patient's need for the second eye. Thank you very much for your kind attention. And
thank you, sir. Very excellent presentation. Now I would like to call Dr. Rajesh Joshi, sir, about the preoperative workup, because the preoperative work is very important before the cataract surgery. So over to you, sir.
On the preoperative evaluation in cataract surgery to get crisp and clear vision. The aim of the preoperative evaluation is to have assessment about the ocular and systemic health, identify any potential risk factor that may affect surgical outcome, optimize patient's visual outcome after surgery, and educate about the surgery and manage the post-operative expectations. The ocular history is the most important part of the examination. Previous intraocular diseases, injuries, other eye cataract surgery need to be known so that you can modify the intraocular lens power accordingly. The systemic history in the form of diabetes mellitus, hypertension, current medications are important, particularly in those patients who are taking alpha blockers. They may have floppy RE syndrome during the surgery. If the patients are on antiplatelet agents, they need not be stopped nowadays because we are performing clear corneal incisions. But you must know whether they are on antiplatelets or not, and whether they are on long-term steroids or not. These things should be seen clearly. If the patient has got acute dacryocystitis, ectropion, they should be corrected before you take these patients for the surgery. Slit lamp examination is the prime importance while you perform the cataract surgery, because they may have some endothelial deposits, keratic precipitates, and corneal opacities. The endothelial count, if you have access to specular microscopy, you must do the endothelial count, because sometimes endothelial may look healthy but they have such type of problems, guttata under retroillumination or endothelial polymorphism, that should be taken into consideration. Now pterygium, if in many Indian rural patients they have pterygium coexisting with cataract also. So, and with high expectations, you must tell them that you may have a suboptimal outcome because of the corneal opacities, particularly patients having such type of pterygium. Now I will take this case scenario. 60-year-old female with cataract and pterygium. Patient wants premium IOL. How to proceed further? The patient has got steep curvature. You can see here and on the topography. And the effect of pterygium on corneal abrasions, everyone knows that they induce corneal abrasion, and once you remove the pterygium, they may get reduced. So we perform pterygium surgery first in this patient, then cataract later on. The patient was kept on lubricating drops for 3 months because patient may have dry surface post-operatively. Now about the keratometry. Ideally, you should measure keratometry more than by one instruments, and it should be reliable and repeatable. Anterior chamber, particularly shallow in intumescent cataract and anterior subluxated lenses, that should be taken into consideration. It may be deep in myopia or subluxated lenses. Gonioscopy, if you find some abnormalities, they should be seen, and accordingly you can modify your surgical steps. Particularly in shallow chamber, you may have to use high molecular weight viscoelastic, protective endothelial viscoelastics. Now reaction of the pupil, if patient has got RAPD, then that suggests that some retinal pathology. Whether the pupil is dilating or not, that should also be considered, because you may have to use iris hooks or iris expanders during surgery. Morphology of the lens should be taken into consideration. If it is a brown black cataract, and if you think that you may not be able to do by phacoemulsification, you can consider removing them by small incision cataract surgery. Posterior polar cataract with obvious dehiscence, they may create problem intraoperatively, so that should be explained in the preoperative session only, that you may have dehiscence, may have to undergo second surgery if something goes wrong. Retinal examination should be done in each and every case. Biometry, as Dr. Harbans has suggested, you must do it properly, and the requirements are keratometry, axial length, and IOL calculating formula, IOL power calculation formulas. Keratometry, you may consider manually, auto keratometer, topography, or optically, but optical biometry is the gold standard nowadays. The sources of error in the biometry could be poor fixation, dry eye, or irregular corneas. 1 diopter of error in the measurement will cause 0.9 diopter of refractive error post-operatively. Measurement of the axial length, the present gold standard is by optical biometer. But if you don't have access to optical biometer, you can always consider doing it by immersion scan, because that is again gives accurate reading. Now tips for accurate measurement of the axial length: ensure that machine is calibrated well. Echoes from cornea, anterior lens and posterior lens surface are perfect, and there should not be, you should not push onto the cornea, particularly if you are using the applanation biometer, because it can cause error post-operatively. These are the types of various formulas which can use in various eyes. If you have hypermetrop eyes, you can use Barrett Universal 2 or Hill RBF formula, but the most accurate one is the Barrett Universal 2 formula. Toric or non-toric. This is another case scenario. 58-year-old male having epithelial basement membrane disease with K reading of 45 vertical and 47 horizontal. This was the dilemma whether to put toric IOL or to treat this basement membrane disease, and then go again for IOL power, and then whether to consider this patient for toric or non-toric. So we debrided this epithelium which was loose. The K reading was improved to 44.5 and 45. So this was treated with monofocal IOL. Another patient having dry eye, having same problem, the biometry changed from 20.5 to 18.5 diopter because of treatment for dry eye. So big no to premium IOL if patient has got severe dry eye. So conclusion, preoperative evaluation is very important each and every case, and counseling before cataract surgery must for crisp and clear vision. Thanks for your patience listening.
Thank you, sir.
Thanks, Rajesh. We will have question answer after we have time for that, and with the good question prepared by the Dr. Paresh and Urvija. So we will discuss now.
Now I would like to call Dr. Srop Ashok sir to talking about the biometry, choice the right one. Thank you, sir.
Good afternoon, everybody, and thanks, Dr. Rajiv Chaudhary, for having me invited here to participate in your course. For sharp vision, we have to have a biometry, and we have to choose the right one so that we don't have any problem with the patients. We have to answer so many questions. Now, to see, even for normal situations, it is very necessary because we have to have a precise IOL power. It is a must, and now because the premium lenses, to avoid the post-operative refractive surprises, and we want to have a heavy patient. Now, meeting with the patient's expectations, confidentiality, must have state-of-art technology, accurate biometry, advanced optical biometers, and appropriate formula. And to consider other factors also, when you decide the power and the incision, you must know your surgeon factor. You must do the preoperative markings, particularly in the premium lenses and the toric ones. You must consider the special situations which you should cover in your counseling. And when you have some problem, you can go on online calculators. Newer generations optical biometers we have now, at least not at the personal level, but at very common centers, and we must take the full advantage of these, like IOL Master 700, Lenstar, and the Argus. They are based on different principles. Of course, till date, I mean, little before some time, the IOL Master 500 used to be the premium this thing, and the Lenstar. But now they have come with the more improvisation, and they are much better. They work on a different partial coherence interferometry, the low coherence interferometry, or the SIFT SSOCT enhanced keratometry. So they are the different principles. But the most important is these instruments must measure the keratometry, the corneal diameter white to white, the central corneal thickness, the anterior chamber depth, the axial length, the aqueous depth, pupil size, lens thickness, and the angle kappa. And there are different formulas which are very popular, the SRKT, Hollandaise, Higgins, Barrett, Hopper skew, and they have different applications too. So if you have a less than 20 millimeter, then you can have Hollandaise 2 or Hopper. Between 20-22, which is very common, you can again go for Hopper skew. 20-24.5 SRKT. At 24, more than 24.5, 26, you can go for Hollandaise 1, more than 26, SRK2. And whenever you have a problem, you can, of course, go online and find out the IOL power. See, usually, because I've been using since 500 IOL Master, and only two formulas, less than 22, Hopper Q, more than 22, SRK2, and if necessary, then we take the help of online calculators. And these are my observations. Even we have compared with the Hopper Q, Barrett, and you can see that, except these case where it was the SRK2 formula, the IOL power was 25.5, and the Barrett gave 24, and then we used 24. We went for the 24, and then the landing was 0. Of course, newer generation formulas, you can go, they are obviously available now, and we must use it. And this is very simple. They give you the all pictures where you put your torics, etc. there are some special situations which must consider. Of course, the percentage of overall these cases are very less compared to the normal one. But however, the dense cataract, posterior polar, post-LASIK, these patients are coming up now. More and more patients are for cataract surgery. Pediatric patients, myopic, silicone-filled eyes. So you have to have you have to modify the calculation. But the newer generations, they like Argus. They are now an AIOC2023. They give you the exact measurements even in these situations. See, where we have compared our data with the IOL Master 700 and Argus, we have two friends in Surat and they have used this one. And we found that they are almost comparable, except the Argus, there where the plano was about 53%. Otherwise, it is all comparable. So we thank you very much, but let me tell you before I conclude, the best biometer is for yourself. The doctor is the best biometer. You have to apply your mind, you have to apply your experience, and then you can modify here and there so that you have a minimum, most happy patients. Thank you.
I request Dr. Chaudhary, what biometer you use, and is there any advantage of?
I am using IOL Master 700 and Lestar. They give a more precise, and it helps give an OCT imaging also by macula, so you know the macular function also, and its penetration is comparatively better than
Even in dense cataract.
We will have the question that later on, just we finish the talk.
Okay, sir. I would like to call Dr. Urbicha. He's talking about the role of the topography and eye trace in the cataract surgery. Over to you.
This is all friends to improve the quality of post-operative quality of the vision. So we are covering the topics so that with add-on feature you can give a very good post-operative quality.
That's it.
Next one.
Thank you, sir, for giving this opportunity. I would like to discuss something upon aberrometry and topography and its role in cataract surgery. We know cataract surgery nowadays, it's a refractive surgery and patient needs a premium vision at all ranges. We have extended range of technologies, good IOL calculator systems, IOL Master 700, Lenstar, as sir was talking about, high-end phaco machines, premium IOLs. But even with all of this, sometimes we face refractive surprises in a lot of cases. And to answer this comes the help of eye trace, which is aberrometer with a corneal topographer. It is a 5-in-1 system which gives us ray tracing aberrometry, the whole eye wavefront, a corneal topography, autorefraction, autokeratometry, and also pupillometry. So this, the main function of it is, it gives a whole eye wavefront along with corneal topography. The whole eye wavefront will measure total aberrations of the eye, and corneal topography part will measure the corneal aberrations part. When we subtract this total aberrations, and from this, when we subtract the corneal part, we get the internal aberrations, which mainly consists of the lenticular part. And this is how we can evaluate the results of our premium lenses, and also it helps in planning of what kind of lens you want to plan, toric, multifocal, or a aspheric lens. Eye trace also gives us a dysfunctional lens index. That means it assesses the condition of the lens in preclinical cataract cases also. So this was a post-LASIK case. Few years down the line after LASIK, he complained of symptoms of glare. On checking topography first, it was stable. On doing the slit lamp examination, lens was clear, but patient was accepting minus was fair with -1 cylinder. So on doing an eye trace, we observed that he had a high internal aberrations and a low dysfunctional index, lens index, which was coming down to 2.6. 10 is a very good lens functional disindex, and coming down reduces the lens quality. So here the lens quality reduced from 10 to 2.6, and internal aberrations were very high, whereas the corneal aberrations were completely normal. So this will suggest it is a preclinical cataract and not a lens regression, not a corneal regression after a LASIK surgery, and you need to plan a cataract surgery early for this patient. Then it also gives us information about angle kappa, angle alpha in cases of multifocal, because if you decentered, if angle kappa is very high, angle alpha is very high, so the lens, the center of the lens and the center of the visual axis are way apart, and this can cause complaints of glare and halos to the patient. This is one simple case with the night rays where you can measure an angle alpha, you can measure corneal aberrations, and if any of those, if corneal aberrations are high or angle alpha is more than 0.5, you must avoid a multifocal lens. iTrace also gives us a very good simulation vision of a patient. This is a simulated picture of how the patient is perceiving a letter E at a high, at a mesopic pupil, and at a 2 mm pupil. It gives a range of simulated vision at all sizes of the pupil, and you can assess if patient is complaining of double vision, glare and halo, and it basically demonstrates an actual vision problem to the patient as well as to the doctor where the patient lies. I would like to discuss two cases, very interesting cases. This was a 40-year male, underwent both eye cataract surgery with a monofocal lens, and best corrected vision was 6.6. He complained severe dysphotopsia after 3 months of the surgery. So when we did an eye trace for him, earlier he was given all the lubrications and lubricants, but he was not satisfied. The eye trace gave this simulated vision picture, which was very blurred, internal as well as the corneal. The dysfunctional index had come down in case where there was a clear lens, clear IOL. Even then it was giving a dysfunctionalness index of 2.6. DLI was very low and high internal aberrations. And if you see, the aberrations increased from 1, this is 1 mm pupil size, it increased at 2, and it increased very much at 4 mm. So he was complaining glare and halo more at night. iTrace also gives you a toric alignment check. So here the corneal astigmatism was just 1, and IOL astigmatism was given as 1.5, whereas this was a simple plain monofocal. There was no toric implanted. So why was this giving a toric alignment here at 1.5 diopter? So when we checked on the slit lamp again, we realized that that toric correction is coming due to the capsular bag fibrosis. And all these findings just help you be more confident about how you want to plan this. Capsular fibrosis was assessed on iTrace. So when we dialed the bag, the fibrosis was released, and you can see the post-op iTrace improved the simulated vision and the post-op simulated vision. It improved significantly the internal aberrations. This is pre-op and this is post-op. Internal aberrations reduced drastically and patient was happy. This is second case of post-RK. Right eye cataract surgery was planned. ILMaster failed to capture any keratometry in this. So keratometry was captured on a topographer. So we planned topography on a Scheimpflug based and also on a Placido based topographer. So this is a pentacam picture. This is a very widely used topographer nowadays. So we did a pentacam topography. Pentacam gave 11 diopters of astigmatism at 164 axis. There is a very good EKR report. It's a equivalent keratometry reading given by the pentacam. It takes care of the anterior as well as the posterior corneal astigmatism, and it gives you an equivalent reading what you should plan. Ideally, a 4 to 4.5 mm size of the pupil is what is usually planned. It gives you a good reading. So the EKR map gave a astigmatism of 6.23, whereas the normal refractive map was giving 11 diopters. It was way different. So it reports the keratometry value just adjust for the back and surface power deviation from the average. This is the AIOC based topography for the same RK patient. Here the astigmatism was coming -7.8 and the posterior corneal was coming +1.7. So if you subtract 7 with plus, it comes around to be same as -6 cylinder. So it matched with the Holiday EKR report on the pentagam. So we planned a 6 diopters of cylinder with +19.5 sphere, and residual refraction came out just 0.75 on patient, and we got a very happy patient. So thank you very much. I would just conclude that aberrometry and topography can help with patient education, preoperative counseling, better outcomes and satisfaction of the patients, and postoperative assessment as well. Thank you.
Yeah, thank you, Dr. Vivija, for that wonderful talk. Now I call upon Dr. O.P. Agrawal for his talk on toric marking, how to manage perfect IOL alignment.
Good afternoon. At the outset, I thank Dr. Chaudhary sir for giving me this opportunity. For sharp and clear vision, each and every step of cataract surgery is important, and that's why toric marking as well as toric alignment of lens is also very important. And why this is important? Because we are in the era of refractive cataract surgery, and for all of us, the cataract surgery is becoming easier day by day. But the result of cataract surgery must be equivalent to refractive surgery, and which is the most difficult part of cataract surgery for all of us, especially when we talk about the toric IOLs. And that's why very few of us adopt toric earlier in our cataract surgery portfolio. These are the options available for corneal astigmatism correction. But we usually choose the first choice always is more predictable is toric IOL. Though we have the laser in our hands, but toric is still the first choice. So how we have to do? For this, we need to do perfect toric marking as well as perfect IOL alignment. Both the things are very important. So toric IOL needs proper alignment to provide refractive outcome in cataract surgery, and we have tools and softwares to increase the efficacy of toric lenses. So these are the tools available: reference marker, axis Mendes ring, and axis marker. There are tools where we don't need two-step marking, that is simple slit lamp. So basic toric marking techniques need two-step marking. First step is the reference marking, which we do in sitting position outside the OR, and then we have to shift the patient in OR, and that is second step is axis marking. And here we need incision location and lens placement. So why we need two-step marking? We need two-step marking to avoid the effect of cyclotorsion of eyeball in lying down positions. So we have to mark 3 reference marks in sitting position outside OR, and then 3 marks in lying down position, 1 for incision location and 2 for IOL placement. So these are the instruments which need two-step marking. Then if we want to do this step with a single sitting position, then we need only slit lamp. With the help of slit lamp, we can do marking. And how we can do? This is my own technique.
Of slit beam can be adjusted according to requirement of toric marking. This can be done from 0 to 180 degree. After installation of Paraken, ask the patient to sit upright in position, and after painting the Sinskey hook with the help of marker pen, adjust the slit beam and directly mark single point. Now we have to mark 2 points 180 degree apart for toric lens implantation. These are the 2 marks. This is how we can mark 2 points 180 degree apart for placement of the lens. This is the axis marks for toric IOL placement. Post-operative patient. In this patient, even on first post-op day, we can confirm the placement of the IOL in the bag, and we can confirm the exact axis of the lens implanted in the bag. This is the technique by which we can confirm the stability of the lens in post-operative period to see the rotational stability. Thank you.
So
Thank you.
there are different softwares also available, which gives marking as well as alignment both. The available are Varion from Elcon, Callisto from Zeiss, and smartphone apps are also available. I am using Varion since last 8 years, and I am very happy because impact of IOL rotation, toric IOL rotation is very high. With manual marking, there are chances of head alignment and axis changing. The rule of game has changed. The Varian image guided system compensates for head tilt. So even in sitting position and when the patient is lying down, this software, I'm not going in detail because there is time constraint. So with the help of this softwares, we can plan our incision location. If we are not comfortable, we can plan our own incision location like 120 degree, 140 degree. If the incision location is 180 degree and we are not comfortable, we can change and we can plan the lens accordingly. So these are the softwares available and which are very easy to do the marking as well as align the lens. So a small video.
Sir, please summarize, sir.
Yeah. So this video, this image guided system will give the exact location from where we have to take the incision, do capsular axis, do astigmatic correction, as well as to implant the lens, centration of the lens, as well as centration of the axis. All can be done with this. Thank you. Thank you very much.
Thank you, sir. Very excellent talk. And now I would like to call Mahipal sir, and is talking about role of the femto laser and the cataract surgery. Over to you, sir.
Thank you very much. Thank you, Rajiv, for always having me in your course. I'm supposed to be talking about how to get clear vision. I'm not talking about basics of femto or anything, but how to get clearer vision with the use of femto laser. So this is a famous saying which says life can only be understood backwards, but unfortunately it has to be lived forward. So in retrospect, you can say that this is what should have been done or this is what it is, but ultimately as of now, you are looking at what future things are holding for us. So for clear vision, as has been impressed by my previous speakers, the astigmatism management is something that is gaining ground significantly. And this is a market scope study of the year 2019, which says that only 33% of patients with significant astigmatism are getting their astigmatism corrected, and 49% did not even have anything done, and the rest are the LRI, the LASIK, etc., and the femtosecond laser that is being done. So when you're looking at the femtosecond laser, the femtosecond people, obviously there is a slight contradiction in terms because they are also manufacturers of IOLs at times and they want to sell more of toric IOLs. So they have not concentrated much on astigmatism correction in the LRIs that is there. So however, the catalyst system has moved. That's a system I use, so I'll be talking about it. They have moved on to the catalyst. So COS is the catalyst operating system 6.0 version, and now also 7.0 version, which we'll be talking about. So the 6.0 version gives you simplified astigmatism management workflow. It increases the operational efficiency because you don't have to feed in much. It's an automated system with artificial intelligence, which is going to give you where the LRIs, etc., have to be placed, and it gives superior results which are there. So there is a direct entry of the pre-operative data. That means whatever is the pre-operative data that can be entered directly. There is a built-in nomogram. So you had the Donald feed, and now you will also have the Stevens nomogram. You had nomogram for penetrating penetrating LRIs, and now you will have for intrastromal. That means that they are not full penetrating. So that is going to be a built-in nomogram, and there is also radial laser alignment marks. So even post-operatively, you can see whether your toric lens is in position or not. So there are two lines that come on the axis where the lens has to be placed as the toric alignment marks. So this is just to show you. This is it will tell you as you feed in here. This is the axis that is fed in here. You have the optical zone at which you want to do 8 millimeters, 7 millimeters, etc., and length. So this is automated, and these are the two LRIs, which is 17 degrees is the length of the LRI at 8 millimeters, and this
has to be matched with cyclotorsion compensation. That is very important for LRIs, that cyclotorsion compensation has to happen. So this was linked with a kind of a pentacam which is called as Cassini. And we impressed upon that you have linked it with Cassini, but most of us do not have a Cassini. That's the name of an equipment. So how do you work and how do we kind of get it? So this was more like a little manual thing. But when you, for those in the studies who had the Cassini, when you looked at the sample size, the refraction, etc., the alignment marking, as also you looked at the IOL alignment error, you could see that there was very little error. So that means this was found to be much better than manual markings that you have for making LRI or for the placement of the toric lens. So this was automated and it gave you a good outcome that is there. So this is, you can see the laser alignment marks. So this is the line that I'm talking about that you get on the cornea. And this is the Technis toric family of IOLs which one is looking at. So the hitting the target and it remaining grip with this thing is that, I don't know, for those who know, there is the Technis 2 variety that has come, which does not have a smooth glistening free edge, but it is serrated. So the haptics are more sticky. And that's all that they have done. So therefore rotation goes down. This is the COS7 system, which is just, we'll be starting work on this as soon as I go back from the conference. So this is a limited market release and then will become a market release. In this particular thing, it is being linked now with the IOL Master 700, which all of us have. So from a Cassini, it is being changed to the IOL Master 700, like you have the Callisto system in the microscope that is linked with the IOL Master 700. This is going to be, and the calorimetry data will automatically populate arcuate incisions and toric mark calculation. So this is something which is important. This is what you are going to get. And iris registration aligns the patient's steep axis. So whatever is the steep axis that you get on the IOL Master, that is going to go to the catalyst system and that is going to align. And as I told you, the Donald field is there, the Stevens nomogram, they will automatically calculate the arcuate incisions where you want, and adaptable incision preferences with surgical customization options for total keratometry. The other thing is that the LRI can be based on either the total keratometry or the anterior keratometry. Right, some surgeons are believing that it's the total keratometry based on which you should do the astigmatic correction. So it can be done on both. And how you want to write the toricity for the LRI, whether with the rule, against the rule, or oblique, will be there, and optical zone preferences will be there. Toric alignment calculator customized to surgeons, so it can again be on total keratometry and also include the surgically induced astigmatism. Automatic cyclotorsion compensation will be there. Now, the other thing that is coming in to get clearer vision is to do a repeat laser, to do a primary posterior capsular axis which is there, so you can have a clear vision even subsequently. And the same thing LSCS for pediatric population, where you need to do a posterior capsular axis in majority of them. This machine will allow you without having to buy another laser LOI for these particular cases. So this again is going to help you in clearer vision. The other thing that is being worked upon is called as LYRIC, that is laser induced refractive index change. And this laser induced refractive index change without making perforations can be either on the cornea or on future intraocular lenses that are being manufactured. Like you have the light ablatable lens. Similarly, the femtosecond laser can be used on intraocular lenses that have been implanted, and if you have power, so you can use a femtosecond laser to change the refractive index or the curvature or the astigmatism on those lenses. So this is the future that one is looking at. And there is another thing which is the artificial intelligence, which is, I think Rajiv has this. This is the Lens AR system with Streamline 4, which gives you an integrated swing through camera, this thing, imaging, which identifies the nuclear density as to what is the nucleus density of a cataract, and basis that it will say what cuts, how deep, how many energy, etc. that has to be done with the laser. So it is an artificial intelligence that is working, and this is what it is. It can give you the patterns. See, this is category 1, 2, 3, 4. That you can see as you keep on going into harder cataracts, it's going to customize the nucleotomy, the techniques that has to be done, and this will enable the surgeon to make also microcorneal incisions on the cornea in pseudophakic patients who additionally independent of the arcuate incision. So you can see that these are laser incisions that you can do. It also makes at present in the capsulotomy the incisions, so that the toric alignment can be kept. So there are two ways by which you can see toric alignments, intraoperatively and postoperatively, that you can have a capsular knuckle and which is at the axis at which, or you can have alignment marks on the cornea which are going to stray, which are intrastromal. So summarizing the horizon, I think in the femtolaser there is room for improvement in logistics, smaller, more mobile services. Primary posterior capsular access will be coming. Future laser technologies will allow refractive enhancement and treatment of the implanted intraocular lens even after it has been implanted, to enable target correction to get clear vision in vast majority of cases, and lyric on the cornea via compaction of collagen fibrils. So it is not cutting, it is compaction of collagen fibers, can be done without refractive surgery. And maybe tomorrow presbyopic correction by inducing spherical abrasions on the cornea could be on the horizon. So friends, this is something on the femtolaser which is there on the horizon to give you clearer vision. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Maipal, for the nice presentation on the upcoming things in the femtolaser.
Now I request Dr. Paresh Nishlani for further panel discussion. He has a case scenario, I suppose.
Yes, thank you, sir, for giving me this opportunity. So it's basically a question round, and we're free to ask any question from the audience as well. So, sir, I would like to know that now, as we are becoming the diabetic capital, and many more patients are also having good control. So, patients who are having a diabetic, long-standing diabetic, but no evidence of any retinopathy changes, how much multifocal planning can be done on these patients, and how much advocacy is done? Puren sir, please enlighten us, sir.
It's a wonderful question, and it is there in all our minds. What I personally do is, it depends on the age of the patient, and if the patient is young and diabetic, the patient is around 40-45 years of age, he has to live for another 20-30 years. So in such cases, now we have other options. So I will go for extended depth of focus EDOF lenses in such cases. And second thing, which and I will defer going for a trifocal or a multifocal or bifocal lenses. And second thing is the diabetic control. What is the diabetic control? If the patient's HbA1c is high, more than 7.5 or 8, so again I will prefer going for EDOF lenses, whatever may be the age, because they can develop CME anytime, and they can develop diabetic retinopathy and other CNVM also. So EDOF lenses will be my choice in such cases, and this is what. And otherwise, in rest of the cases who are having good diabetic control, we can consider multifocal IOLs, and because that gives a better quality of distant, intermediate, and near vision.
Thank you, sir. Also, now we are seeing many patients who have been operated post RK, post LASIK, coming for cataract, and sometimes we have burned our hands as well in getting great post-operative surprises. So, what would be the pre-operative planning and pre-operative IOL workup per se for these patients? Mahipal sir, please enlighten us.
Unfortunately, except for the LASIK, hyperopic as also myopic, you have the nomograms Barrett 2 modified that you have, so that's not a problem. If you have the IOL Master 700, you can do that. You don't have any nomograms for the RK bit, because RK was not universally done, and I am not aware if other people are aware that there is any specific nomogram that you have. The IOL Master doesn't throw up any nomogram. So the issue here is that whatever you did, you can get a TrueNet K that can be done on the Pentacam, and basis that you can do the IOL power calculation. The other rule of thumb is that you have to, depending on the number of incisions, you need to overcorrect whatever you are getting on the IOL Master, and typically the overcorrection could be anywhere between 2 to 4 diopters. So that is a rule of thumb, but basically do a TrueNet and use that to do that. There is often a lot of astigmatism in these cases, and fortunately the astigmatism is not thrown out of much because this astigmatism doesn't change too much. So we have had reasonably good results with toric IOLs being implanted in post-RK patients, and obviously with the new things coming in of the piggyback lenses that are available, if you do end up in surprises, one is that you can explant if it is early enough, But otherwise, you can also go ahead and do a piggyback, let the whole thing stabilize for about 3 months and do a piggyback, or you can do a surface ablation in these cases. Normally, when you have hyperopic shifts for RK, I don't do laser vision correction on them, but if you have a under correction or a myopic, etc., then you can do it. But in a post IOL, if you have a refractive surprise, you can go ahead and augment it as a bioptics procedure subsequently with that. Post LASIK, I think, has hardly remained a problem because the lens power calculations with the IOL Master 700 are reasonably accurate. The only question is that what lens at times to put. Some people are becoming very aggressive and even putting trifocals, but I think there is a duplicacy of a contrast problem in both of them. So I normally, and from my point of view, what Purendra said, EDOF is almost out of the window for me. I don't use EDOF lenses anymore because an extended monofocal, and now the Hoya people are also coming out with an extended monofocal, which is an Impress. So you have the INs and the Impress. I think it almost comes up to the level of EDOF for intermediate vision. And just doing a mini monovision for them gives them a great outcome that is there. So for a LASIK patient, I will prefer to go in either for a monofocal or an extended. Basically, my monofocal practice is again out of the window. So I am using two types of lenses. Either I'm going right onto the trifocal, Synergy, etc., or Zeiss or whatever, or I'm using the extended monofocal, which is the IHands, and now basically maybe the Impress. So these are and obviously the toric variety of whatever is required when the toricity is there. So those are my lenses. EDOF is neither here nor there, and there is a price difference which is there, and the patient is not very happy with and you can still give them the intermediate without talking to them anything. In an IHands, it is only 2,000-3,000 rupees, say, more than a monofocal lens. So you don't really need to talk to them, ke bhai main kya kar raha hu, kya faltu, and they don't complain of any dysphotopsias.
Thank you, sir. Dr. Shroff, sir, you wanted to add in something, sir?
I just wanted to know from Mahipal and other experts, because the hyperopic RK, so they keeps on changing the refractive power. So would you prefer the premium lenses, or just how to explain, particularly when there is a refractive surprise post cataract?
I never go in for premium lenses in RK. The only premiumness that I go in is toric lens. But from a trifocality or this thing, I don't go. I don't know. No. Surprises?
I think he has already addressed by piggyback lenses and by laser vision. When the stability is there after 3 months of the IOL implantation, if you are if it is large surprise and you want to explant and exchange the lens, then it is okay in the immediate.
Have you done the PRK after putting the RK? Yes. You have the surprise, and then you can do the PRK.
PRK can be done. You can have the. नहीं hyperopic LASIK में इतना change नहीं होता सर. Post RK there is a hyperopic shift that we are seeing as the patient is aging. His power goes on to +2, +3, +4. It keeps on changing. One of the things that has been described, I have done in 2 cases. I haven't really, now the number of cases are less. Maybe Madhya Pradesh has more cases. But I think cross-linking has also been described as a procedure for stabilization of the cornea post-RK. So maybe, I don't know if anybody else has tried it, but that can be done.
We have done in the few cases of not the cataract, that RK operated with the fluctuating vision. Because they have the incision are very deep, so they are the fluctuating vision, and the spectacle number are rapidly changing. We have tried the cross linkage, and that gives some stability too. 5 minutes.
Okay. Sir, one also very important question now, as because of digital screens and environmental factor, dry eye is rampant, and patient come up, they want premium and they want freedom from glasses post cataract surgery. So what would be the ideal pre-operative planning, and do we choose multifocal or premium IOL in these kind of patient?
Yeah, in fact, the incidence of dry eye is very high nowadays, and particularly if young patient comes with cataract and dry eye, we have to manage dry eye first and then consider patient for cataract surgery. For dry eye, you need to have a pre-op workup very meticulously. If the patient has got meibomitis, you have to treat that. If there are surface problems, you have to treat those problems. And you have to modify the lifestyles also in this patient, because if they are computer user, they may have to reduce the computer time or social media time, whatever they are doing. But in fact, there is no contraindication of putting premium IOL in this patient if you control dry eye. That I showed one patient in my talk, that one patient had a severe dry eye, but after the control of dry eye, definitely you can implant premium IOL. As such, there is no contraindication.
We can take one question short, so that
Yes.
if there is any important question,
Yes,
if
sir.
you
So
please.
now in market we have these lenses available which are having positive abrasion, negative, and zero abrasion. So how much consideration does preoperative aberrometry counts in these premium patients? Purin sir, if you would like to.
How much abrasions?
Yes, sir.
Preoperative
And what
abrasion
lenses
or
to be
this
used?
abrasion lens?
I
that
think
for
this
negative.
was something sometime back. This was the thing which we used to take care and to consider our planning of the IL power and these positive and spherical abrasions which the patient had. But definitely in cases of post laser vision correction cases, post LASIK cases, which have got a high with myopic high spherical abrasion, they get their induced high spherical abrasions are there. So we will go for the Technics kind of lens which corrects maximally the spherical abrasion. While in hyperopic laser vision correction, we will not go for any spherical, and zero spherical aberration correcting lenses should be used in hyperopic LASIK correction patient. Otherwise, in routine patient, earlier I think 3 years, 5 years back, I used to look into it, but now I don't. I mean, new lenses, I don't think they are very important. Sir.
Anything? Any question? One more.
Yes,
so
sir.
we have
So
1 minute.
basically,
So any
I think
question-
apart
any question from the audience side?
asphericity, there is also the achromaticity that is coming into play.
Any question
And,
from the audience?
Chromatic
Anybody?
aberration correction is also something. All your camera lenses are achromatic lenses. So achromaticity just now has only been introduced in Synergy, but the next generation of Symphony is coming with achromaticity, and sooner I think it will be the standard of care even for monofocal lenses. So that is something, and there was always a talk about looking at what is the positive spherical aberration that is there on the cornea, and you titrate it, but does it not help in some patients to leave behind an abrasion? So there are a lot of these things to say, whether the Bosch and Lomb touts that I am zero aberration. So even if there is decentration, it does not make a difference. Some say 0.27, some say 0.21, some say 0.14. So that is, the jury is still out on that. But yes, an aspheric lens or a negative aspheric lens is definitely better than the earlier lenses, and an achromatic lens is definitely going to, because that makes sense. If you reduce the chromatic aberration, the quality of vision at contrast is going to improve.
Thank you, Maypal.
Thank you,
And it's the end of the session. I thank you, my all speaker and expert panel and convener and the participant. Yes, thank you.